Dr. Butler?
Yes, Utapa ma'am, please go ahead. We are live now.
Okay. A very good evening to everyone. We are back once again with our second webinar of the series on empowering women on preventive healthcare. This is the week for global action on non-communicable diseases, or NCDs. And the NCD for us, which is in our point of attention, is cervical cancer. So to welcome you all on behalf of ASSOCHAM, we have with us Commander Navneet Bali. He is the co-chair, ASSOCHAM Healthcare Council and Regional Director North of Narayana Health in Delhi. Commander Bali has served the Indian Navy for almost 30 years before he ventured into the healthcare industry in India. He has been the Group COO and Head of Business at IOSPL, Unit Director of Rockland Hospitals before joining Narayana Health. In his current role, he's responsible for overall strategic planning, operations management, service excellence, and business development in the northern region. Commander Bali is a master's in finance and BSc from the Jawaharlal Nehru University. He has undergone multiple professional trainings on finance and management from institutions such as the Edinburgh Business School in Scotland. Commander Bali.
Thank you very much. Morning to Dr. Mel and good evening to the lovely panelists today. Thank you very much for having me on board. And I think it's a very, very pertinent, important, and wonderful topic that we want to discuss. You know, many years back, I was listening to Dr. Devi Shetty, the chairman of Narayana Health, and he was talking about empowerment of women. You know, he asked this simple question to the audience, you know, what's the difference between if a woman were, you know, to go to work and peace and in the same family.
Ritika, can you please check the tech?
Yeah, I think there is a bandwidth issue from his end. Yeah.
We can't hear him. Okay, as we wait for Commander Bali to join back.
Yeah, so here I am back, Sudapa.
Yes.
As you know, technology. Anyway, so you know, he asked this simple question. You know, if a woman were to go and earn 10,000 rupees and a man were to get 10,000, what's the difference? And you know, he answered himself that you know, when a woman goes and earns 10,000 rupees, she brings back the entire 10,000 rupees into the family, and the entire family benefits. And when a man goes out and earns 10,000 rupees, he spends some amount of money on himself and then maybe brings some money, you know, home. And that much importance to women empowerment. And how do you empower women, or how do you empower anyone? You empower somebody by giving them education. You empower people by giving them economic freedom. You empower people by giving them freedom to think, to talk, to be able to live their life the way they want. And you also empower people when they are healthy, you know, when health comes in. And when a woman is healthy, it means that the entire family gets benefited. And once the entire family gets benefited, you know, the entire nation gets benefited. And when nations get benefited, the world gets benefited. All societies where women are healthy, where women are empowered, you know, are societies which are at the top of value chain of this entire, you know, universe that we live in. And the topic that we talk about today, especially in the context of India, where you have almost, I think, 25% of global deaths by cervical cancers happen in India. I think the statistics are very well known. And we still have a very, very preventable disease. Of course, the incidences might be coming down now, but still long way to go before we can actually make a difference and, you know, easily sort of bring down this number drastically across our country. You know, having been in healthcare for some time, I also felt that many times when we talk about preventing diseases and to go for preventive health checkups, psychologically many of us do not want to do that because we feel that the results might be something that we are not very comfortable with. And so there are a whole amount of issues which are economical, then there could be issues which are psychological, there are issues which are cultural. And but yes, I think many of these resistances in many vaccination programs across the world have been overcome by persistence, by being at it, by and educating people on it over and over again. And we have seen that these many of these resulted in wonderful ways in which human beings benefited as far as their health was concerned, as far as preventing many of the deaths which were possible. And I don't think we could have had a better panel today than what we have today, Sutapa. And it's an amazing panel with Dr. Mel joining and with everyone else here on board, which they will be coming in and discussing this very pertinent and important topic. And I think all the best to the panel. And I'm very glad that I could speak two lines to just open up this discussion. I'm sure we're going to have a cracker of a discussion today. And thank you very much for having me on board. All the best.
Thank you so much. And taking a leaf from where Commander Bali left, that empowerment. In order to empower women, you need to build conversations, because we don't talk as much about cervical cancer, unlike the other cancers, though it is a preventable cancer. So I believe that these are opportunities for us to talk more and more. This is a series of 3 webinars. As we said, this is the second one. So in the first one, we talked of, what all we need to understand about the importance of talking cervical cancer, the elimination strategies. In this one, we are going to talk about the safety and efficacy of the HPV vaccine. And to do that, we have some of the best speakers. As Commander Bali said, we couldn't have got anyone better than this panel. So we'll introduce our speakers. I'm extremely honored to introduce Professor Neeja Bhatla, Professor and Head, the Department of Obstetrics and Gynecology at the All India Institute of Medical Sciences, New Delhi. A celebrated clinician, teacher, and researcher in the field of cervical cancer, Dr. Bhatla is an authority on cervical cancer screening in India and HPV vaccination. Her body of work over the years on cervical cancer prevention ranges from screening to vaccine trials, to epidemiological studies, to developing guidelines, to leading associations. She has played leadership roles as the founder of multiple associations. She leads various expert groups, develops strategies, and continues to contribute in building the evidence for cervical cancer prevention. A multifaceted personality, Dr. Bhatla has collaborated with some of the most brilliant researchers in the country and abroad. She continues to represent India across international forums and is currently an invited member of WHO Director General's Technical Group on Cervical Cancer Elimination. With over 240 well-cited research publications to her credit, Professor Bhatla has recently been awarded the Honorary FRCOG in recognition of her contribution to women's healthcare globally. I have Dr. Smitha Joshi, the Program Director at Jehangir Clinical Development Center in Pune. Dr. Joshi has a brilliant career as a researcher in cervical cancer prevention in India. Her years of work has been focused on cervical cancer screening and HPV vaccination, with a particular interest in high-risk women living with HIV. Dr. Joshi is currently holding multiple positions as a senior scientist at Prayas in Pune, along with being a program director at JCDC and project consultant at Ruby Hall Clinic in Pune. Her current research on HPV vaccines includes following up on girls who have been vaccinated over 10 years ago. Serum Institute of India's phase 2 and 3 HPV vaccine study, cervical cancer prevention study in HIV-positive female subjects. She's a colposcopy trainer recognized by the ISCCP and IFCPC. She has also been recipient of the UICC ICRED Fellowship at IRWHO and the Fogarty Fellowship at Brown University, USA. An MBBS and PhD, Dr. Joshi has over 50 publications in peer-reviewed national and international journals. Thank you, ma'am, for joining us. I've kept the best for the last is Dr. Melvin Korn, Medical Affairs Executive Director for HPV Vaccines at the Merck & Company, USA. An epidemiologist and a pediatrician, Dr. Mel has a distinguished career of 20 years in government public health, working on a wide range of public health issues, including communicable disease control, chronic disease prevention, maternal and child health, injury prevention, and environmental health. In Merck, he has played leadership role as Global Director of Medical Affairs for adult vaccines. Dr. Melvin is a BA from Yale and an MD from Harvard and a Master's of Public Health in Epidemiology from Tulane School of Public Health and Tropical Medicine. He has authored several white papers and over 40 articles on public health in peer-reviewed journals. We also have with us Ms. Neeta Arora, who is the principal and co-learner at Sri Venkateshwar International School in Dwarka, New Delhi. A leader with academic excellence, Ms. Arora has 39 years of teaching experience, 24 of which has been in school leadership, and that has been recognized with the Principal Talent Award conferred on her as recent as May 2021. A British Council School Ambassador, a CBSE Master Trainer, a Teacher Skill Auditor, she has also been the winner of National Extempore Speech in 2019. She is a postgraduate from Delhi University in 2 disciplines, zoology and education. She, in fact, was the 3rd topper in university in B.Ed. Thank you very much, ma'am, for joining. As I said, that we are in the 2nd of the series of our webinars, and we intend to talk on the safety. But before we start off, we would like to have an understanding or overview of the perspective of cervical cancer prevention. And I would request Dr. Melvin to kindly give us an overall perspective of what it is to talk about cervical cancer and why are we doing that.
Thank you very much. And thank you to ASSOCHAM for organizing both these important webinars and for inviting me to participate today. You know, we're living in very interesting times, and I say that not just because of COVID, which is of course on everybody's mind, but we really are in front of a historic opportunity around the world to eliminate cervical cancer. In 2018, the World Health Organization announced its cervical cancer elimination initiative, calling on countries to reach targets of 90% for vaccination, 70% for screening of women, and 90% for treatment by 2030. So this is a global effort, and India has a critical role to play in that. Cervical cancer is the 2nd leading cause of cancer among women in India, with roughly 100 to 120,000 cases diagnosed each year. And from the global perspective, as was already noted, almost a quarter of the world's cervical cancer cases come from India. So if we're going to reach cervical cancer elimination globally, we've got to get India fully engaged in this battle. Now, fortunately, we have some really good tools, and the vaccines that we have available are really terrific as well. Over 90% of the cases that get diagnosed in India each year are caused by the HPV types that are in MSD's 9-valent HPV vaccine. So what we're doing today, and all of you have a very important role in helping galvanize India and helping the world eliminate cervical cancer, building on the very, very powerful and impressive history that India has with preventive efforts, particularly in children. Now, HPV causes a number of other cancers in men and women. I wanted to mention that. And these also can be greatly reduced by vaccination, as well as genital warts, which, while not a fatal infection, is really terribly debilitating for people who experience it. So what do we know about the power of this tool? Well, in Australia, which was one of the first countries to implement a national program, and they have a program both for males and females, they have seen the rate of infection with the types of HPV in the 9-valent vaccine decline by 93% in just 9 years. So, you know, in the public health world, that's a very, very impressive kind of result. Of course, I know from some of our other distinguished panelists, I know we'll be hearing a lot more about the development and safety of these vaccines. I just wanted to note that the phase 3 clinical trials that allowed these vaccines to be licensed, there were over 19 of them, and they involved almost 50,000 females and males aged 9 to 45. So this is not a new thing. This is something that has been very, very thoroughly researched. We also have long-term follow-up data now showing that in vaccinated girls, the protection lasts at least 12 years, and it appears to last longer than that, although we only have the time that we've been able to follow up since. And we even have data from Sweden now documenting reductions in cervical cancer after vaccination. That takes longer to demonstrate because cervical cancer has a long latency period, that is the time between infection and disease. But what about safety? Well, the safety of the vaccine has also been thoroughly reviewed in over 15 studies by government, scientific societies, and independent researchers. So this includes the World Health Organization, the US Centers for Disease Control, Health Canada, the European Medical Agency, the Australia Therapeutic Goods Administration, and that's not the full list. But I think this gives us very strong confidence in the safety profile of this vaccine. And perhaps the best evidence I can give you about this is that over 127 countries around the world have national HPV programs in place. But of course, vaccines don't help anybody unless they're actually administered to people. Sitting in a vial in a refrigerator somewhere doesn't help. So I hope that with today's event, we can all help give you the information you need to advocate for HPV vaccination and to help protect Indians from this really, the awful diseases that can occur. So thank you, and Stapa, turn it back to you.
No, I'll have more questions for you later on in the discussion. So we'll be hearing a little more in detail. I wanted to talk on the safety with Dr. Nija Bhatla, but she's having some issues with her internet connection. Ma'am? Yes. Oh, wonderful. Right on time. Thank you so much. That's perfect. Absolutely. We heard Dr. Mel talking of all good things about the HPV vaccine, that there is, a virus and there's a vaccine. I think nothing could be better than that for cervical cancer. But your experience of working with cervical cancer in India has also given you a lot of opportunity to see what it is like to administer the vaccine. So my first question to you is that, how safe is the vaccine?
Yes, hello, Sutapa, and it's really such a pleasure to be on this. So thank you very much to all for the invitation to be here. It's always a pleasure to have these ASSOCHAM programs, which are so well attended, and to meet all the wonderful panelists with so much experience. And I have to say, yes, that we have been fortunate that we have worked with each and every one of the vaccines along the way, because we were part of the trial for the bivalent, as well as for the non-valent, and as well as now for the Serum Institute. So these have been part of trials which were informing the licensure. And then we have worked extensively with the quadrivalent vaccine as part of our IARC study.
We're losing her. They just wait for a minute for her to join back. Yes. Yes, ma'am. Yeah, we just lost you for a bit.
I'm not sure whether I'm heard or not.
Yes.
Yes.
Now you are.
Okay.
Yes, we lost you for a bit.
Effectively, we've worked with bivalent, quadrivalent, nonavalent, and now with the Serum Institute's vaccine as well. And broadly, I can tell you that all these vaccines have been completely safe. We have had
An unstable connection.
And we have seen that what the CDC has said effectively is true. It's as safe as the tetanus toxoid. That's what they say, and that's what we agree. Because broadly, yes, patients will complain of pain at the injection site. Maybe some may have a little fever. We have dark skins. We don't usually complain of redness. So these are not usually even of the category that they have caused patients to drop out from school or from their workplace. They are very mild side effects which are easily handled. And serious side effects which have occurred have usually not even been within the 2 weeks of administration, and where they have been also, there is nothing in those then that is a cause and effect relationship with the vaccine. I think everyone can rest assured millions of doses have been used worldwide. WHO continues to be satisfied about the safety. There should be no doubt in anyone's mind that we are very cognizant of the need to have safety when we talk prevention, and this vaccine is completely safe.
Ma'am, you've been part of virtually every trial of the vaccines that you talk of. So what kind of tests are conducted to ensure the safety and efficacy? And what were the endpoints? Like, are we talking of preventing the cancer or preventing the infection? You're on mute. Yes.
So usually every vaccine goes through 3 phases of trials, and the first one usually devotes completely to safety in a very intense way, in that a very small number of patients is taken at that time, volunteers I should say, not patients, because this is not a therapeutic one. And they are monitored very closely in almost like an ICU type of setting, where if they have any reaction at all, they can be safely looked after. After that intense phase 1 scrutiny, where even the slightest variation in any of the parameters is looked for, then we move on to looking at the phase 2 trials, where we look at the doses and we see what is suitable for the patient. And then we move on to the phase 3 trials, which are larger trials, which are then looking at the efficacy. But all the while, even after it is marketed, the post-marketing surveillance continues, and there are systems set in place in every country for the monitoring what is termed broadly as AEFI, the adverse events following immunization. And the pediatricians, for example, do it all the time for the childhood vaccines as well. At any time there is an adverse event, there are adverse events and then there are serious adverse events. So any adverse event is reported to the local authorities with a rider from the doctor who was managing the patient. Do you think it was caused by this or it was not? And then it is pursued accordingly. But if there is any concern, that batch number is looked at, is reported. If there were any such concern, the entire batch sales would be stopped until it had been scrutinized and tested again and made sure that it is suitable for further use and so on. So the surveillance never stops and everyone continues to look very closely at these.
So when we have these trials, what is the endpoint that we look at? Is it preventing the cancer or preventing the infection?
So, when it first started off, it was in the case of cervical cancer, because we know the natural history. We know that it's a sequence of events which starts with an incident HPV infection, which must become persistent, which means at least 6 months it must remain there, the same HPV type, and then lead to changes of CIN 2 and 3, which is the precancerous stage, before they will go into becoming cancer. So this is a kind of a pyramidal system, because a lot of women will get the infection, only about 10% will persist, and only a fraction of them will go on. So it's a pyramid, really. So when it first started out, it was more about looking at the potential to prevent this precancerous stage, because the whole process takes about 10 to 15 years, which is a very, very long window. So it was more about looking at the ability to prevent the infection and to prevent the precancer, which is actually a good enough marker, because that's the way screening has always worked. You screen, you find these precancers, you treat them, you prevent cancer. Here you vaccinate, you prevent precancer, you know that you will prevent cancer. So the initial strategy was that if the vaccine can show that it prevents the precancer, it's good enough. And then it became that even if you can show that there is persistent infection is prevented, is also good enough. Today, the Drug Controller of India says if you can show comparable immunogenicity that is also good enough, because if we know that a certain immunogenicity has worked for the quadrivalent vaccine to prevent, then the same immunogenicity comparable will be fine even for this one. So it has been a varying consideration as we have gained more experience. And now we have data. We have data from the Nordic countries to show the actual reduction in cancer among the vaccinated population as compared to those who did not receive a vaccine, or the historical rates of cervical cancers. So there is a lot of compelling evidence that shows that the vaccines do prevent cancer, but it is not necessary to show this to get a stamp of approval.
Normally, when we have these vaccines, why do they have to be tested in the country where it will be administered, even if you have the data?
So there's always concerns about ethnicity and its impact. Having said that, I'm not sure that I know of a single vaccine where ethnicity ever mattered. But there is always a concern that there may be some some ingredient that may be not suitable for a particular population, or something like that, which makes them do the tests in the country so that they can be doubly sure about how it will work. But today, with such a lot of global movement and all kinds of people everywhere, I think even if there's been concerns, for example, with COVID, that if you see the numbers in the US, there are all types of ethnicities over there. I'm sure each one need not even repeat it, because there will be enough of every ethnicity that have received it, for example. But no, these are the rules that have been made. The drug controller has set a certain standard. They want to be sure. They want to. In the case of prevention, we always err on the side of caution, because it's not, you see, the risk-benefit ratio is completely tilted by the fact that these are healthy people. Because if you were already sick and you were taking A treatment and B treatment, you already had a significant risk, for example, if it was a cancer drug trial. But here you have a healthy population, so you can't afford to take chances. So everyone wants to be doubly sure.
Now that the vaccine is safe, how do you find India is preparing for an increase in demand of HPV vaccines? Do you see that there was going to be a lot of takers for the vaccine in the population?
I think we were beginning to be very optimistic with the WHO call for elimination. We were seeing a lot of sort of interest amongst the gynecologists. We were seeing a lot of interest amongst spreading awareness by advocacy groups. And we were hoping to be able to influence policymakers in a very, very positive direction. But I have to say that unfortunately, with the coming of the pandemic, everything was kind of tossed, because the most important deterrent has been, the camp-like approach, which Dr. Shankar hates the word, and he says we must call them outreach clinics, which is true, but people understand when you say what a camp means. And that was full of, having a lot of people coming on the same day, crowding in a small period of time, with volunteers who were giving off their time. So they also wanted to do the maximum work in the minimum amount of time. So everyone was called at very short intervals. And that doesn't work in pandemic settings anymore. You need to have distance. You need to have all those things. So, and people were not really stepping out of their homes. They were not coming to healthcare facilities. And because of the concern that there may be an anaphylactic reaction, you want to give the vaccine where the child can be observed, and you want to keep her there for at least 15-20 minutes after the vaccination. So it limits the kind of movement that you can have in terms of numbers. So for various reasons, there has been a problem. Then again, the costs have been a consideration, because people have lost their jobs. There's been economic instability. And this seems to be the easiest thing to postpone when you're looking at money, because this is something like, okay, it's all right, I'll do it next year. So, for various reasons, it's not been a good time for us. And I hope with things coming back to normal, that we can put an accent on something and bring the focus back.
It's wonderful. We'll have more questions for you at the end, ma'am. And I'll now go over to Dr. Joshi. You know, the vaccine, it seems, has promise. It's extremely safe, as Dr. Bhatla says. But in the COVID times, again, it's difficult. But I still want to know the number of vaccines that are available. Do you think that all of them are equally effective?
Okay, so currently, thank you, Dr. Sutapa, for giving me this opportunity. Currently, we have two vaccines that are available in India, the bivalent vaccine and the quadrivalent vaccine. The 9-valent vaccine has undergone studies, as Dr. Bhatla has mentioned, but is yet to be approved by the DCGI in India. And we have a quadrivalent vaccine that is manufactured by Serum Institute of India, which is identical to the quadrivalent vaccine of Merck. And this vaccine is currently in the last stage of its development in the phase 3 study. And we should be having some results by the end of next year or mid 2022. And it is likely to be available soon next year.
So the vaccines that we already have, they're equally effective. If you see, and we know that these vaccines are for adolescent girls. That's what the adolescents, in fact, are focusing in India for girls. So does the virus infect an adult woman and an adolescent girl in the same way? Why is it for adolescents only?
Yeah, so the vaccine can infect adult women, but the difference is that when it infects the younger girls or younger women as they start their sexual debut, the infection that is acquired at that time is likely to remain persistent, is likely to remain there in the body for a longer duration of time if it doesn't get cleared by the natural immunity of that girl or that woman. And then it is likely to cause more cervical abnormalities and then subsequently cervical cancer if not detected and treated early. Adult women, even if they get this HPV infection later on in their life, the physiology of the genital tract, it changes in such a way that this infection in the adult life is likely to be transient. It's not likely to be persistent. And for the development of cervical cancer or cervical precancer, there has to be chronic persistent HPV infection. So that is the difference between a young girl who has just started her sexual debut getting infected with HPV as compared to an adult woman who gets infected with HPV, probably maybe because of her sexual partner. New sexual partner in the adult life.
As Professor Bhatla said, that there are virtually no side effects. But, you know, as a mother who would like to get the daughter vaccinated, what are the primary concerns? What are things that she should keep in mind before getting the daughter vaccinated?
So we have very good response to vaccinations in India so far, as we've seen even with the COVID-19 vaccine. The major hurdle, as I see from the lower income group and the middle income group, is the cost of the vaccine. Even if the parents want to give this vaccine to their daughters, the main concern is the cost of the vaccine. And then for the middle income or the upper middle income group, their concern is about, you know, the need of giving this vaccine. So there is a need for educating doctors, mainly the GPs as well as the OBGYN, to whom these mothers, you know, ask their concerns about HPV vaccination. They have to recommend this HPV vaccination to the daughters. And so that there'll be more uptake from those who can afford this vaccine from the private healthcare. Whereas for the public sector, the main hurdle is the cost of the vaccine.
And hopefully that will be part of the universal immunization program in some time. And that is, I think, is going to take care of a lot of these issues that you have. You have personally worked with high-risk women, you know, who are HIV infected. What has been your experience like? This is a very special group that you work with.
Yeah, we've been working with women living with HIV for the past 12 years, specifically on the cervical cancer prevention. And these women, they're generally dealing with a chronic disease, which is chronic manageable nowadays with the help of the antiretroviral treatment. However, there is still stigma in the community for this HIV disease. And when these women come to know about cervical precancer or cervical cancer, it's really very difficult to counsel them. So, and then we can't do at that stage when she's having cervical precancer or cervical cancer. So, what is important for these women and also for women in the general population is to get screened. For women living with HIV, we start screening early. We start screening them at the age of 25, and for women in the general population, it is at the age of 30 years. But early screening, and then maybe screening with a more accurate test, which is the HPV test that we have, which is the most objective test for cervical cancer screening. So screening them early and then treating them for pre-cancer is important for women living with HIV. Unfortunately, screening is, although it is advised for women attending the antiretroviral clinics in India, screening, cervical cancer screening is offered in the gynec department, and there's a lot of loss during this, travel from the ART center to the gynec OPD, and then reporting of the report back to the ART center, and then calling that woman back to the gynec clinic. There's a lot of loss to follow up. So what is important is setting up cervical cancer screening for women living with HIV in the ART center itself.
We hope that that happens soon, because these are very immunocompromised women and they need special care. Hopefully that will be done. I'll now come to Dr. Melvin. You have already explained a lot of it, but I want you to expand a little more on your views. So as we all know, the disease burden of HPV is very, very high. But how significant is HPV vaccine in saving lives? You did mention, but if you can just expand a little more on that, the significance of the vaccine.
Well, I think that it's fair to say that the vaccine is extremely significant, and that's why WHO included that 90% vaccination target in its call for elimination. And I mentioned before that Australia has seen a 93% reduction in a relatively brief period of time in HPV infections. So I think this will save a lot of lives if it is widely implemented. I think that's undisputable.
So with this, health and wellness is critical among young boys and girls. Can you just, explain the gender neutrality of the vaccine? Is it a good idea to vaccinate both?
Yeah. This is an area that is evolving around the world. But I think there are several very strong reasons to vaccinate males as well as females. So first is the fact that, well, women get HPV from males. So why should women be the only ones to have responsibility for preventing this infection? It just doesn't make sense, right? Then is the impact on transmission. I mean, as I said, women get this infection from males. So if you want to prevent women from getting infected, it's common sense. You should be vaccinating males as well. And then finally, the males also directly benefit from HPV vaccination. Now, obviously, males don't get cervical cancer, right? But there are quite a few other very serious diseases that are caused by HPV. So things like genital warts, which I mentioned, anal cancer, penile cancer. So these are terrible diseases, again, that can be prevented. Now, I did want to say a word or two about head and neck cancers. This is not currently included in the indication in India, but in the US, the vaccine is indicated for prevention of head and neck cancers as well. And in the context of a discussion about vaccinating boys, this is particularly important. What we've seen in the US, as we have stepped up our vaccination and screening campaigns, is a very dramatic drop in cervical cancer, as like what's been seen in Australia. But we have also seen, because of this drop in cervical cancers, we actually now have more head and neck cancers in the US occurring each year than we do cervical cancer. So I think this has really accelerated the push to vaccinate males. And also, if one looks at the program in Australia, which I already cited as really a first-class, world-leading program, they have had gender-neutral vaccination for many, many years, as soon as this was included in the label. So I think those are all pretty strong arguments for vaccinating males as well.
Countries have taken up HPV vaccination and included it as part of the national immunization program, which I think is extremely encouraging. If you can throw a little light on that, how many countries and what are they seeing as the impact?
Yeah, so every year we're seeing more and more countries get on board with this. Currently, I believe the number's about 127 countries that have national programs with a variety of vaccines. I mean, our vaccines are the market leader, particularly since the 9-valent vaccine provides the broadest protection available. But there are other vaccines also that are all very effective that are out there. The serum vaccine that's under development has also been mentioned several times. So, there's a lot out there. And actually, that maybe I can make another point about supply in that regard. Some years ago, when all of the HPV program started, things were a little slow to take off. But somewhere around 2017, the requests for HPV vaccines really started to skyrocket. And I think it had to do in large part with the WHO call for elimination. Now, vaccines are not like most other consumer products, for example. You can't just manufacture a whole bunch more next week because you have increased demand. It takes a lot of time and investment to make that happen. You have to build new plants. This is all strictly regulated, so those plants have to be inspected and so forth. And this is a good thing. I mean, this is what guarantees the safety and quality of these vaccines, but it can't happen overnight. Well, I'm very proud to say that MSD has invested tremendously in its vaccine production. Since between 2017 and 2020, through a variety of methods, we were able to almost double the amount of vaccine that we were supplying to the world. And we expect that to double again by 2023. So together with the other manufacturers, I think supply should not be a barrier to countries, even enormous countries like India, implementing these kinds of programs. Very, very important.
Extremely encouraging that, at some point of time when India takes it up, I believe all the manufacturers will be ready with enough stock for us, and we will just get started and roll it out, because it's as you said, it's a huge country, it's a huge population to cover. Thank you so much. We'll have more questions for you. We are getting it from the audience in the chat. I'll take it after all the speakers are done. Now I'll go to Ms. Smitha Arora. The reason why she is here, part of this discussion, because a very special position that she has, this is an adolescent vaccine, and adolescent girls are in schools, and most programs across the world have been through the school-based approach, and it has worked really well. So we would like to hear her views on that. Ma'am, to start with, in the school health program, how important is preventive healthcare?
When we bring in a lot of children together in a school environment, we have to make sure that we do not have hotbeds of transmission within the school. So talk about COVID only, take the example. There were many people who did not want to get themselves vaccinated. But the moment I told my teachers, either you get yourself vaccinated or you get your half-day leave deducted, they opted for vaccination. I mean, I had to literally use this, because if teachers are going to be in contact with the students, we should not be treated as socially not responsible. And we have to make sure that the children coming in contact with adults do not get it. But at the same time, because the children are not yet vaccinated, and when they come from homes where the adults are not vaccinated, they may bring the virus to school. Not only cross-infect their peers, but also cross-infect my staff. So we have made a precondition for children who attend offline classes to have all the adults, eligible adults, vaccinated before the child can be made to attend school. So this has worked in two ways, that the parents and the other adults in the family have also gone into vaccination program if they wish to choose offline classes. So in a way, we are now trying to have mass immunization against COVID. And COVID is not a cheap vaccine for a lot of people. Started with a costly one as well. But still people have overcome their initial fear and now going for vaccination, though there are still myths and stuff. So school is a very important vehicle of social change. I remember when I was a young girl, smallpox vaccine was administered to us without our parents' consent. It's simply a part of school health program. Nobody asked the parents, and the parents had no say in that. All the kids would be immunized, and that is why we could eradicate smallpox from the world.
So do you talk of preventive
I'm
healthcare?
talking about polio as well. Similarly, the polio vaccine centers were school. Easier for parents to go. Now, if a school teacher or a principal or even the parents who are kind of aware, talk to each other and say ki we have to protect our girls, because 70% of all women cancers are cervical cancer. And all of us are very worried about cancer. That is why we take proper diet, and we are worried about the chemicals that we're consuming, the pollutants that are inhaling. We're worried about dengue, we're worried about AIDS, we're worried about hepatitis. Hepatitis virus vaccine did pick up. Typhoid vaccine did pick up when people became aware that it's pretty safe. AIDS vaccine we could never find. And we're worried, why can't we find an AIDS vaccine? Now, since there is a vaccine against cervical cancer, and it is not that expensive that it cannot be, probably cannot be taken in by a large number of population. But yes, 70% of people who are below poverty line, I think the government could subsidize. I believe there was a lot of talk in the WHO and the government and the planning commission about this program. Half the people wanted it, half do not want it to become a political question. That is the same thing happened with the COVID vaccine also. But ultimately, government had to understand that COVID vaccination has to be made into a mass immunization program if you want to get rid of it. Otherwise, they thought maybe India will escape. And we did not really promote COVID vaccination right from the beginning. Now, before it becomes too late, it should be started. Now, there are two ways of, as you suggested, universal vaccination immunization program. It gets included and automatically everybody has to get it. No say. And if supposing you cannot, there's another bright idea just came to my mind, that you cannot travel to another country till you are vaccinated against this particular disease. A girl from 9 to 26, and I mean, or maybe the pre-adolescents, then maybe all of us will have to go in for vaccination. For example, when I travel to Africa, I have to get yellow fever vaccine, whether India has yellow fever or not. And I cannot come back to my country if I don't show that I have got this vaccine within this 10 years period. So immunization also gets a boost when there are strict quarantine laws, one, or as you said, universal immunization, or there is public awareness through mass media. Schools also have a role to play in talking about how to prevent, because we all know prevention is better than cure, and there's hardly any cure for cervical cancer. But if it is detected in early stages, then probably fourth stage cervical cancer can prove to be fatal as well. And fifth thing is that it gets covered in your insurance scheme. If the government is not subsidizing it, or even insurance, I believe there are certain insurance companies which cover all vaccines, including cervical cancer too. So the parents take that program, they would definitely get. As Con said, Melvin said, even boys should be immunized. Here we're only talking about girls. I think ultimately it has to reach to the boys also, 9 to whatever age, because it is contagious. Anything which is contagious has a preventive vaccine, then we must make use. And a vaccine that has been tried, a vaccine whose newer versions have come, more effective versions which are more or less active against all the 9 variants of the virus, not the earlier ones which are effective against just 2 or 4 variants. US has made it more or less compulsory. He's giving the example of Australia. India should not wake up too late. At least for COVID, we woke up by a year late, but we woke up.
Yes, in some time, I believe that India government will also approve that. But as of now,
I'm sure.
it
But
is for
what
girls.
ASSOCHAM is doing is also raising voice. I remember promoting cervical cancer in my staff in 2012.
Okay.
We got PAPS test done for everybody. We had a health camp, but we could not make it compulsory. We said anybody who's comfortable getting pap smear test done. There are now better tests available. And there was a talk about some women, but it was basically for girls. So we thought if the teachers are aware of it, they will be able to talk about it in classes, the biology teachers, the life skills teachers, not why only life skills, anybody and everybody. And there has to be webinars in which parents are a part of it. And if you share some data or some poster or some, I would say, write up with us, we can forward it to our parents. And meanwhile, if you can send it to other schools, you can also send it to other schools so that it becomes a mass movement, people understanding what is it about. First of all, this vaccine does not seem to have any side effects. There are two things which hold people against it. One is the side effect. Second is the cost. If you can bear that cost for 2 or 3 doses, I think this will be fine. Otherwise, we've got to wait, but government has to subsidize too. Or maybe when the mass vaccination starts happening, the cost of the vaccine will also come down.
Normally, when you talk of preventive health, if we are talking of cancer to young girls, how do you think they're going to respond?
Everybody is scared of it. Everybody is. I mean, people know that nowadays there are very good treatments available, but it is a very long process and there's a lot of side effects and there are a lot of problems, and it's very, very expensive treatment. Long drawn. Even after you get cured of cancer, you continue to take anti-cancerous medicines for years, and then there could be side effects. No girl would like to lose her hair. No girl would like to lose the capacity to even reproduce. No girl would like to have a life which is like a vegetative state, or to have a lot of problems related with menstrual bleeding. Because any sort of unnecessary bleeding, a girl or a woman gets really, really worried. And with people traveling a lot, and society undergoing whatever change it is undergoing, I think it's very, very important to safeguard our girls and to provide them better health facilities and hygiene practices.
You have the experience of dealing with a lot of schools. Of course, you have your own school, but you have worked across platforms. Do you normally see that parents and teachers engage in preventive health or discussions preventive health for their daughters?
They do. We have organized a number of webinars, say on COVID only. We have organized webinars on vector-borne diseases, on dengue prevention, on malaria prevention, on polio vaccine. You'll be surprised. Anything that happens in society, we try to talk about it. Whether it is, we even have done that you must go and cast your vote. That's a simple thing, but the school always takes it upon its responsibility to share social messages. And this is also like a social service a school would be doing for the young girls and their families.
Wonderful. Everything sounds positive. Great. On that note, we'll open up to questions from the audience here. We have questions in the chat box. I'll take some of that from there. So, Dr. Bhatla, do I have you? Okay, great. The first question would be to you is, what is the best age for HPV vaccination?
I would be inclined actually to say that the day you wake up and decide to take it is the best age. But no, if we're looking at a large target population, then we say under 15 for sure. And you can start even earlier than that now. Even at 9 to 10 years is a good age to start. And that gives us actually a new flex, because SAGE has come out with this conditional recommendation actually 2 years ago almost, that you can actually give young girls aged about 10 years a single dose now and give a delayed second dose 3 to 5 years later. So that gives you a flex of waiting for the data on a single dose to emerge, and the possible chance that you may get away with just the one dose. So any girls who are under the age of 15 and who have not got any immunosuppressive conditions, or they are not on immunosuppressive medications, are fine with just the 2 doses. Over that age, the recommendation is that they should receive 3 doses. So the best time is before any sexual activity.
We do hear that, as you said, there could be a 1 dose. Just I'm curious to know that, the age is below 15 and it's like 9 is the cap there, that start from 9 to 15. Can we not go lower than that? Because from 0 to 5, all the vaccines are given and it's easiest to get the kids at that point of time. So can we not go lower?
So there was some thinking that we should look into that and club it with the earlier childhood vaccines, but I don't think we have any data at this time, nor do I know of any trials that are ongoing to be able to get this information and to be able to move there. So the best we have right now is to do it with the 10-year, because there are a couple of injections they will go in for at 10, and that's the best time to combine it. They can be done on the same day, and that's not a problem. And that makes it much easier if there is an option to for those who are considering costs or logistics, both ways. And if they're sure they will find the girls, it gives an option to take the delayed second dose recommendation.
If I can add, I am aware of a few trials that are starting to look at this, and I think we're likely to see more in the near future. Of course, the results don't, we won't know tomorrow. And I think the durability question is particularly important if you move the age lower, because you want girls to be protected when they become sexually active later in life. So that's going to be a key question that will have to be answered with that as well, by the way, as with the one dose investigations that are going on. So there's a lot of activity happening.
So I'll take a question that I had for you here is that, if a girl is vaccinated early, like between 9 and 15, and the cancer shows up in adulthood, so is there enough scope that, the protection, can it last that long?
Right. Well, the vaccine hasn't been around long enough for us to absolutely, clearly, unambiguously answer that. But all of the indications are yes, that the protection is long lasting. I mentioned we've had our long-term follow-up studies with the 4-valent vaccine. We now have out to 14 years. And it's really remarkable in the vaccinated group, no cases of cervical dysplasia appearing. So, this suggests that not only is the protection at least lasting to 14 years, but it's likely to persist well beyond that. I think many experts believe that it will provide lifelong protection. Again, the vaccine hasn't been licensed for that long, so we can't really say that with 100% confidence, but I think we believe that the protection is very long lasting, particularly if you've had at least 2 doses, 3 doses for older people as well.
From there, I'll go to Dr. Joshi. You have the results of the 10-year study in India. So what do you see that, does it, the effect remains that long?
Yeah, so in our study, the initial plan was to look at the efficacy of 2 doses versus 3 doses. But because of some interruptions during the course of the study, because of events that were not related to the study, we now have a large number of girls who have received 1 dose of the vaccine, 2 doses of the vaccine, and 3 doses of the vaccine. So what we have seen so far is the protection that is offered by 2 doses as well as 3 doses. 1 dose offers equal protection when compared to the 2 dose and 3 dose. As far as the persistent infection or precancerous changes are concerned. So 1 dose practically is as effective as 2 or 3 doses. There are several studies that are comparing 1 dose with 2 or 3 doses. These are randomized controlled trials. Ours is an observational cohort, but all this evidence shows that 1 dose is going to be as effective as 2 or 3 doses.
That's very encouraging to see. There's a question here that can one be vaccinated at 60 plus and if diabetic? Since we are the question of age, so Dr. Bhatla, I would want you to take this.
There is an upper age cutoff to the vaccine, which is presently mostly 45 years, I think, in most places, though there have been trials going till 55. And the reason for, so the licensure is only for that period for which data is presented as part of the trials. But also we must understand the philosophy that we have to understand that the vaccine is preventing infection. The infection is going to cause a cancer about 15 years down the line. So we need to see the epidemiology. We need to see when the cancer is occurring and peaking. We need to see the life expectancy of the population we're dealing with. And therefore, it makes no sense to give the vaccine at 60 years when the transformation zone's gone all quiescent after the menopause, when the chances that an infection is going to come and take root at the time and lead to the kind of trouble we're talking about. And therefore, there is no vaccination at that age. In fact, that's the age where even regular screening will start.
So that one can be settled. So it has to be vaccination as early as possible. Once you are between 9 and 15, as Professor Bartla says, that's the best age to go for the vaccination. And of course, you would have 2 doses then. So you need to take 3 doses. So you save 1 dose that way. So, and hopefully 1 dose will come in later at some point of time. To Dr. Smitha, I have one question that, what do you think that the vaccination, how it works in HPV naive women, like if they are adults, but they are HPV naive? So does it work?
Yeah, so if they're HPV naive, it will work in the adult women. As Dr. Bhatla has mentioned, the vaccine is approved till the age of 45. However, if we look at the immunogenicity of the antibody response in the older women, it is lesser as compared to young adults and girls. And there's also a question whether these adult women really need vaccine, because all women who haven't received the vaccine in the childhood, and even those who have received the vaccine in the childhood, they need cervical cancer screening starting from the age of 30. So adult women must get screened for cervical cancer, and they must vaccinate their daughters who are in the adolescent age group.
Does vaccine immunity ever exceed the natural immunity? Dr. Kohn, would you like to take that?
Sure. One of the interesting things about HPV infection is that it's a relatively superficial infection compared to a lot of other pathogens. And so we know that the vaccine response to natural infection is just not very good. And people can get reinfected even with the same types. By contrast, the vaccine produces a much stronger immune response. And this is one of the reasons, by the way, why, although of course it's best for people to be fully protected before they ever get exposed to the virus, even those who have been exposed, if they get vaccinated, well, they're for sure protected against all of the types that are in the vaccine. So I think this is yet another argument well, this is one of the reasons why, for example, there's no place around the world that I'm aware of that recommends that people be screened to see if they've been exposed first before vaccinating them, because again, the protection from the vaccine is so much stronger. I will say, this also has some bearing on the 1-dose discussion, because this is what's called a subunit vaccine, meaning it's not the whole virus that people are administered, but just a little piece of it that produces the immune response. And there's no subunit vaccines that are currently available for which 1 dose is sufficient. They all require a priming dose, and then a booster dose. So some scientists have raised the question about whether the particular properties of this vaccine are such, because the immune response is so good, that perhaps 1 dose will be effective. I think the jury's still out on that, but there's a lot of very interesting and suggestive data out there. So we'll all be watching that going forward.
Let's hope that we have all the answers that we are looking for. And now we'll come to rolling out of the vaccination program. Ever since we have Ms. Arora with us, I think it would be a good thing for us to ask us, because we don't get this opportunity very often, that if the government decides to roll out the programs through the schools, how do you think we should approach it?
I would be very happy if schools could become centers of immunization program. They would be safer. There would not be any sick people around. When I go for COVID vaccination, even to a hospital, I'm also worried I'm going as a healthy person. I get the vaccine, but at the same time, will I contract the virus or some other disease? So schools are comparatively sterilized areas in comparison. then it is easy to reach the children very easily. Logistically, children don't have to travel. They don't have to take an off. It can be done within the school hours. Parents could be called and the children can be sent home in case we worried about the side effects for half an hour, 1 hour. And moreover, it is said when a school associates itself with a immunization or any other national importance programs, children attach more values to it. And when the children also attach value to it, they go and talk about it to the parents, and the parents were not aware because in their time this vaccine wasn't there. Like for example, Indian population is not so much aware even of the flu vaccine, whereas in other countries, if the children could not be given COVID vaccine below the age of 12 or 18, they were at least given flu vaccine, but no such program has been launched in our country because we adults are not aware. Why are we not aware? Because nobody has tried to talk about these vaccinations. They don't come under mass immunization program. WHO said minimum there, so the minimum would be taken care of, and their costs have been rationalized. Then government will do free immunization for everybody. Whereas any vaccine which comes in costly ones, so they say, no, that's a parent's choice if they want to take it. I remember giving my kids hepatitis vaccine, typhoid vaccine, though it was not recommended by the government, because we came to know these are being given. There are a lot of things which are happening, but the new parents may know, but the older parents may not know. Because the pediatrician, they stopped going to pediatric doctor. They're now going to a doctor who treats adults, who doesn't talk about immunization program. So 9 to 15 or even girls who are not yet sexually active can go up to vaccination, as she said, to 35, 45. And there's no harm in saving yourself. And schools, somebody has asked a question in the chat, that Mr. Rohit Jain, that have I come across any case of HPV students or alumni? Dr. Jain or Mr. Jain, are you not aware that in our country, anything associated with sexual health is not talked about? People are worried about being ostracized. People are worried that the friends or the school will probably not stop talking to them or may not call them to school. May say, like AIDS, when the moment people came to know somebody has AIDS in this house, the house was ostracized, the children were not allowed to go to attend school. So I am not aware whether any kid or a teacher contracted it and did not share because there's treatment available. But as far as health needs are concerned, you can talk about health needs with everybody, especially with healthy population, because they are the ones who go for vaccination.
When one approaches the schools, do they go through a school one-to-one, or do they take it up as a larger group, like your CBSE schools or ICSE schools or the government schools? How does one approach? What do you think would be the best strategy?
Right at the time of admission, we take the vaccination record of the child and we update it till the age of 10 years. But if we keep updating it, say, till the time the child passes out, we will probably be able to cover these vaccines as well, which are not covered under 10, age of 10. Right now, my school doctor collects data and we fill it with each child. Now, if we include that, whether you've got cervical vaccine for all the girls, even boys, if government feels it is important or doctors advise it, then at least there would be a question in the mind of the parent. I haven't given this vaccine to my child. Do I need it? The parent will go and talk to the doctor. And that would probably start the process. The school will not force. School is just asking a simple question. Has your child been vaccinated against this? And we include HPV vaccine.
If I might add, we know globally that school-based programs for HPV are very, very successful. In fact, the countries with the highest levels of vaccine coverage, like Australia, like the United Kingdom, have school-based programs. I'm embarrassed to tell you that in the United States, we do not, and our coverage is substantially lower than in those other countries. It's really something that we need to be working on. So school-based programs are extremely effective at getting kids vaccinated.
Yes, we just have to add all the possible good vaccine which is safe and tested in the list. They just have to tick yes or no, but that would make them think whether my child should undergo this vaccination. Is it essential? Is it required? They will start talking to each other, to the doctors. And I'm sure doctors like Dr. Joshi and Dr. Bhatia, if they, or their community, or all gynecologists, I'm sure they don't want their patients to come back to them with cervical cancer at any stage. They would advise them to be safe. And the doctors will give their own examples. I've got my own child vaccinated. I've got my, I could not get it, but I've done this. So if they start giving examples of their patients, their family members, I think this will just catch on.
It is wonderful that at that point of time, it was not there, the vaccine. It's available now, so might as well take it. So we come to the end of this. And before I close it, I would like to have a message from each of the speakers. What is it that you would want to share with the women who are listening to this webinar and who would want to take this message forward? So I'll start with Dr. Bhatla. Ma'am, your quick message to all women in India.
I would say, Sutapa, that all women must get their own screening done by an HPV test, and all young girls must receive HPV vaccine. And further to that, if there is an affordability, then even older women, definitely till the age of 26 or 30, should consider taking the vaccine, if they are also understanding that they have to get the screening done as well, and that it's not mutually exclusive.
Thank you very much, ma'am. Dr. Joshi, your last words on the webinar. Sorry, ma'am, I think it's on mute.
I think the message is going to be the same by all the panelists as Dr. Bhatla has mentioned. So I don't have anything to add to that. The message is very clear.
So screening and vaccination has to be there together in order to eliminate cervical cancer, I believe, by 2030 as the target is. We should all look towards that and make the most of it. Dr. Melvin, your final words.
I think Dr. Butler said it really beautifully. I really have nothing to add. Just thanks not only to ASSOCHAM, but also to the listeners for thinking about this issue and carrying this message forward. There's a lot of mobilization that has to happen for this to occur, and it's very exciting that India is really stepping up in a big way.
Yes, of course, we all need to build more and more conversation with more and more different kind of groups so that the word goes around, because we haven't talked of cervical cancer as much as many other cancers. We need to talk more. And I believe that we will come to the next webinar. But the final words have to be from Ms. Arora, who has the adolescents on her side. So we have the science on this side, but you have the main power. So you have to give the last words for this webinar before I close it.
I'll just give you one personal example. When I attained menopause, I asked my doctor, should I go for HRT? Will my metabolic rate come down? I want to be as energetic as I was earlier. Not having estrogen, progesterone, will it affect my system? So one doctor said, why do you have to go for it? Don't worry, you don't need it. A sports doctor told me, are you a sports person? If you're a sportswoman, go for it. Otherwise, not enough research has been done in India on this. So I can't say whether it will lead to any complication later on. I felt bad. I said, why there is not research in this field in India? He said, because in India, women do not worry about their own health. Nobody has bothered about women's health in this country, more about men, when it comes to best education, best food, best opportunities, higher paying job. I mean, same work to men, women. So it's a very male-dominated society in India. That's why women's health is taken a backseat. Not much research, because not many women would come and ask me this question: should I undergo HRT? Whereas in other countries, HRT is pretty common. And then I asked Dr. Agarwal when he was alive once in a seminar. He said, if you take it within 2 years of your menopause, it is very effective. But if you take it after that, then it may lead to some problems. I did not know. So by the time my 2 years was over, so I did not go for it. But I only increased my rate of metabolism and started running more often or regularly daily. So my advice to all the girls and women and the mothers who are listening to this is high time that women start asking for better health facilities for themselves.
Fantastic. I think with more and more
importance in your life, it is very important that even if you are a housewife, you have to take care of your health, take care of your diet, take care of your exercise, take care of your immunization program. Do not neglect yourself. You owe it to yourself and your families.
Thank you very much, ma'am. Because with more and more women scientists coming forward, I believe there's more research will happen in the areas that you want to. So with those words, I close the webinar and I hand it over to Commander Bali.
Yeah, thank you so much. I think it was an amazing discussion today. We just didn't know how the time flew. I just want to share two small things. First is that I got my daughter vaccinated about 5 days back. And, I just wanted to say that, she just got her done about 5 days back. And that's the first thing. The second thing, Sutapa, and I think everyone who's listening here, I think we need to start this as a movement. When Narayana Health wanted to help some poor people get COVID vaccination, we got some of the NGOs on board and we started this program of get one, give one free. And so I think the affluent class of the society and people who can afford it, because the cost comes in between, and many of the NGOs, I think, have to get together where you get one for your daughter or for your, whoever, the lady in the house, and give one vaccine free for those who cannot afford it. I think we will have to do that. And getting the schools on board, I think, is going to be the game changer, Sutapa, as was told by Mel also. I think these 2-3 things we will have to do. And I don't think, any target, because we've seen good vaccination programs succeed in India. And I think these are some of the ways I think which should be done. Thank you so much, everyone. God bless you. Keep safe. That's all.
Have a great evening. Thank you.
Thank you so much. Bye.
Thank you.
Thanks, everyone. Bye-bye.